Definition: failure to thrive is sustained weight loss, failure to gain weight or a persistent fall in weight from the child's normal centile. This excludes constitutionally light child, transient weight loss associated with acute illness. Failure to thrive, FTT, is commonly defined as either a weight for age that falls below the 5th percentile on multiple occasions or a weight deceleration that crosses two major percentile lines on a growth chart. FTT is often expressed by various terms like growth delay, growth failure, failure to grow, growth deficiency, and failure to gain weight. Epidemiology: failure to thrive affects 5 to 10% of young children and approximately 3 to 5% of children admitted in teaching hospitals. Underfeeding is the single commonest cause of FTT that results from parental poverty and ignorance. 95% of cases of failure to thrive inadequate food offered or take. Classification of failure to thrive. Traditionally, failure to thrive has been classified organic and inorganic. Organic causes include following: medical disorder, premature birth, maternal smoking, alcohol use, or illicit drugs during pregnancy, mechanical problems present, unexplained poor appetites that are unrelated to mechanical problems. Inadequate intake also can result from metabolic abnormalities. Poor absorption of food, inability of the body to use absorbed nutrients, or increased loss of nutrients. Inorganic causes. Inorganic causes are those caused by a caregiver's actions. Poor feeding skills on the part of the parent. Dysfunctional family interactions. Difficult parent-child interactions. Lack of social support. Lack of parenting preparation. Family dysfunction, such as abuse or divorce. Child neglect. Emotional deprivation. Failure to thrive classified according to pathophysiology in the following categories: inadequate caloric intake, inadequate absorption, increased metabolism, defective utilization, clinical presentation. Height, weight, and head circumference do not match standard growth charts. Weight is lower than 3rd percentile. Growth may have slowed or stopped after a previously established growth curve. Physical skills such as rolling over, sitting, standing and walking decreased. Mental and social skills decreased. Constipation. Excessive crying. Excessive sleepiness, lethargy. Irritability. Minimal smiling. Avoidance of eye contact. Unresponsive. Diagnostic evaluation. History of prenatal, labor, delivery, and neonatal events. Medical history of child, social history, nutritional history. Physical examination. Denver Developmental Screening Test. A growth chart outlining all types of growth. Complete blood count, CBC. Electrolyte balance. Hemoglobin electrophoresis. Hormone studies, including thyroid function tests. X-rays to determine bone age. Urinalysis. Management of failure to thrive. The primary management of failure to thrive is aimed at reversing the cause of the growth failure. If malnutrition is severe, the initial treatment is directed at reversing the malnutrition. The goal is to provide sufficient calories to support catch-up growth, a rate of growth greater than the expected rate for age. 4 primary goals in the nutritional management of children with failure to thrive are to 1. Correct nutritional deficiencies and achieve ideal weight for height. 2. Allow for catch-up growth. 3. Restore optimum body composition, and 4. Educate the parents or primary caregivers regarding the child's nutritional requirements and appropriate feeding. Parental behavior modifications may need reassurance to help with their own anxiety. Encourage, but don't force, child to eat. Make meals pleasant, regular times, don't rush. May need to schedule meals every 2-3 hours. Make the child comfortable. Encourage some variety and cover the basic food groups. Snacks between meals. Indications for hospitalization. Admission required rarely. Weight below birth weight at 6 wks. Signs of physical abuse. Failure of outpatient therapy. Hypothermia, bradycardia, hypertension. Safety is a concern. Workup needed for organic causes. Nursing interventions. Provide sensory stimulation. Attempt to cuddle the child and talk to him or her in a warm, soothing tone and allow for play activities appropriate for the child's age. Maintain adequate nutrition and fluid intake. Feed the child slowly and carefully in a quiet environment. During feeding, the child might be closely snuggled and gently rocked. It may be necessary to feed the child every 2 to 3 hours initially. Post-feeding instructions. Burp the child frequently during and at the end of each feeding, and then place him or her on the side with the head slightly elevated or held in a chest-to-chest position. Participation of caregiver. If a family caregiver is present, encourage him or her to become involved in the child's feedings. Document the intake. Carefully document food intake with caloric intake and strict intake and output records. Monitor elimination patterns. As food and fluids are gradually increased and the child becomes hydrated, bowel activity and urine production return to normal. Promoting skin integrity. Apply the ointment at least once each shift and turn the child at least every 2 hours. Providing family teaching. While caring for the child, point out to the caregiver the child's development and responsiveness, noting and praising any positive parenting behaviors the caregiver displays.